It's now my pleasure to introduce our speaker this afternoon, Dr. Pam Aaltonen. She's president-elect of the American Public Health Association. Pam is a professor emerita who is winding down her career at Purdue University School of Nursing, where she serves as the associate head of that department. She joined the faculty after having been a public health nurse and administrator in health departments in Minnesota, Oklahoma, and Illinois. So she's served in the roles that many of us have over time. Dr. Aaltonen's research has focused on the implementation of e-government in local health departments. She's collaborating with colleagues whom she teaches a series of interdisciplinary graduate courses in Homeland Security and preparedness on the use of modeling software to improve point-of-dispensing functioning. She's also worked on a global health project with the State Department focused on developing better understanding of how media messaging are impacting refugees. For many years, she's taken students to the Navajo Nation for a clinical experience in public health nursing, which is just a great outreach and teaching opportunity, I'm sure. Having been first introduced to Native Americans in Oklahoma when a novice public health nurse. Dr. Aaltonen is active in her state affiliate, the Indiana Public Health Association, local county board of health, having chaired both of those groups. Her most rewarding accomplishment has been the opportunity to mentor young public health leaders through the Mid-America Public Health Training Center. Her path to becoming president-elect of APHA went through the Great Lakes Coalition to the Council of Affiliates and then on to the association's executive board. So we know we have somebody here who's got a tremendous amount of academic experience, but also a tremendous amount of on-the-ground experience, which is really, I think, speaking to the sweet spot where we're at. So please join me in welcoming Dr. Pam Aaltonen.
As you all know, I'm going to talk to you about Refugee Health at your request. You kind of heard how I got introduced to this area a few minutes ago. Before I get into the topic, I'd like to bring you a welcome from the American Public Health Association. And I'd also like to give a hats off to Region 7. I'm a Region 5 person, so we were very interested in watching the development of Region 7 in terms of its growth and maturity, and we are actually just a little bit jealous that you could arrange the letters to come out to Mink, and we are struggling. We either have to jettison some states or recruit some other states because we make no sense in terms of a region. So I know you've been doing great work, and it is absolutely wonderful. I like going to the Council and Affiliates meetings on the Saturday before APHA and hear about all the terrific things that you are doing, and I'm sure you will do more. I am perfectly fine with you interrupting me if you have questions as we go along. I also want to give you a bit of a disclaimer. I am married to a Finn. He came from Finland to go to college and never went home, much to his mother's dismay. My husband's parents were refugees in their own country. They lived in a part of Finland that was taken over by Russia during the Winter War after World War II. So they were displaced, and so this is an area that's always been of some interest to me. And a couple of years ago, we were able to go back. Russia allowed us back into the territory, and my father-in-law was very distressed because it was just a rundown version of what was there when they left many years before. I also want to mention to you, I have pretty dense slides. There's much more information that I'm going to talk about. You will have access to the slides. Again, I think I have some breaking points where we can just put it aside and you can look at the information in your own time when that gets posted. That's sort of the preference our students have gone to. It used to be that we'd have 3 or 4 words in a slide and that was it and you go on. Now the students want it sort of all laid out, so we've sort of gotten to that habit. I don't know what's happening at your universities, but that's true at Purdue. I was telling some of the people before the session started that it was a little hard for me to walk in and see the Hawkeye because the Hawkeyes are a little hard on the Boilermakers, but I sort of got over that. Yeah. You do try to tone it down, just tone it down a little bit. You heard a little bit about how I got involved in this situation of looking at refugees in terms of, this was a sort of a collaborative between the State Department and the Department of Homeland Security. We got involved with the State Department because the individual who mapped out the Zika virus initially is a Purdue an individual, and they set up an institute. And I was sort of their token public health person. The rest of them were bench researchers, and I was always the one saying, you know, so what? What are we going to do with this? How does this impact practice? So in some ways, I think they thought I was the irritant in the group. But it brought the State Department to our campus, and this kind of look at messaging evolved out of that process. I must tell you now, though, that whole project has totally gone away. You don't find it on the website. It is as if it never happened. The individuals have left. The State Department sort of had a different focus, and so it was a bit challenging to see all of this disappear. There was a lot of work with the State Department with global health initiatives and One Health with veterinary medicine that we were engaged in as well. So we got our graduate students involved in this process, and we wanted them to look at the literature. What are the best practices when it comes to refugee health? What are some of the perceptions and misperceptions? What are factors associated with recruitment? I don't know about University of Iowa. Do you have a lot of international students? We at Purdue we usually get maybe 2 or 3 in the country in terms of number of international students that we have on our campus. So there's not always a lot of graduate students mingle pretty well. Undergraduates do not. We have not solved that particular piece on our campus. So we had them do surveys both internally within the Purdue environment as well as externally. And what they found was most people have very little good information about refugees. There's a lot of misperceptions out there. So I thought I'd spend the first bit of time kind of talking about what do we know. It's an evolving situation right now, but let's look at that. They then, after they conducted surveys, they did these video clips, which were meant to be messages to counteract, try to help people think about how do people become radicalized in terms of their thoughts, either here in this country or elsewhere, and how do we have different, more positive messages available. Those all went to the State Department. Unfortunately, they were going to work on them, make them more professional, and they've just sort of, again, they've fallen away. So hopefully someday we can pull that back out. So what do we have? We have immigrants could be lawful or unlawful. We hear a lot about unlawful immigrants in this country, not so much about lawful ones. I'm sure you have some of these who are here on student or special visas, also people who now have green cards. Just to tell you a little bit about the mood of the country, a couple of months ago we got notice from our state government that they were no longer going to allow anybody with a green card apply for licensure in nursing in the state of Indiana. And we kind of went, what? What is that all about? It was a state person who interpreted a law. Turns out, after it's gone through the legal process, it was an incorrect interpretation, and so it's been pulled back. But we had to notify students that we had in the program about their status and other people who might come to this country. So things are happening and bear watching all over the country. Then you have refugees. I've given you kind of the two definitions, one from the United Nations and one from the U.S. Department of State. These are people who have to flee their country because of persecution, violence, war, and so they come under a different status. You have migrants. Migrants come to this country or another country because they're looking for a better way of life, and they're doing it in a legal process. Then you have asylum seekers, people who are just wanting to come here to spend a short period of time while they figure out they have protection. They figure out if they then fall into the refugee or what their status is. My sense about asylum seekers is that's a category much more used abroad than it is. We have some asylum seekers, but not a lot in this country, as we don't have protracted refugees. Those are big populations of refugees who stay in camps somewhere for a protracted period of time. Up to 5 years is the definition. And some of these people stay in camps for as long as 20 years or more. So if you come into this country, you come into under a family-based process. That would be if I was related to Louise and she was my sister, and I brought in my aunts and uncles and my cousins and my grandparents. That was under the family-based program. That recently has been changed. You probably picked that up in the news, that now it's just your immediate family, your nuclear family, rather than an extended family. I think that has implications in terms of how well refugees settle into a new environment, because their families often are very important to that process. Employment-based, we have employment-based individuals in our area. This too we know is changing. We just don't know what the picture will look like in the future, but somebody is drafting changes to that process as well. The diversity visa, where you sort of just are in a lottery kind of circumstance, and we allow so many people from so many countries to come in on an annual basis, that's going away entirely. The H-1B visa is something we have at the university. I suspect you have at all the universities represented in your states, where somebody comes in who's a highly skilled worker, for example, a faculty member. We hired a young lady who was from China, had come to Minnesota to go to school, graduated from the School of Public Health, was then recruited by our School of Nursing. She comes, we have to write a letter saying we're employing her. We also have to support the legal cost of her going through the immigration process. At the time, our office at Purdue said it would take 13 years for somebody from China to get status, because there's such a long waiting list and you only take so many people from different countries over time. And that was 2 years ago, so I suspect that too has changed. And she has not gone home. She has 2 children back in China. She has not gone home yet because she's concerned about her ability to get back in this country. So unsettled in terms of that process as well. DACA, as you know, is a bit in limbo, and Congress has until now, March of 2018, to make a decision about DACA. And again, our universities, Purdue has a number of young people who are DACAs who we may have to think differently about in the future. There's a lot of support for DACA across the country, but we'll see where that goes. Temporary protected status is gone, and refugees, I'll show you the impact of what's happening with refugees. I think one of the challenges we have is all those groups kind of get conflated. They're all mixed together in people's minds. They don't quite know who you are, why you're here, are you legal, are you not legal, what process was used. So I thought it would help to just talk a little bit about the unauthorized or illegal immigrants. We had a fairly significant number. We have a series of fairly qualified health centers affiliated with our school, and one of them is in a rural community that has an Indiana Packer plant, and they have over the years hired a lot of illegal immigrants to work in their meatpacking process. Their latest effort is to try to think about recruiting refugees to that area as workers, because the illegal workers are sort of taking a much lower profile and kind of slipping away. So they're at loss in terms of how to recruit workers. Numbers are slowly declining. The makeup of the population has shifted too. I think this was pretty interesting, that for the first time, Mexicans are no longer the dominant proportion of illegal immigrants in this country. Asians very much are going up in terms of numbers. Other people who are in this country illegal are people who came here on a visa, maybe they were a student visa, and they just never went home. But they never established any kind of legal residence in this country. And then asylum seekers who requests were modified. So where are we today? There's subtle things happening, again, that are changing sort of the way we as a nation think about immigrants and refugees. The Nation of Immigrants was taken from the vision statement of the Immigration Service. We probably are going to hit the lowest ceiling of refugees since the program was started in 1980. So we know the numbers are dramatically changing. Zero tolerance on the southwest border. You probably hear in the news about somebody who's been picked up by ICE. There was a kerfuffle yesterday. I didn't get all the details about people from ICE and sanctuary cities not informing ICE of what's going on, and so that goes back and forth. I'll try to talk a little bit about the state actions, because the federal government is not the only one that's impacting what's happening with immigrants and refugees in our country. States are doing things as well. I would point you to, at the bottom of the slide, this is from the Migrant Policy Institute. The Migrant Policy Institute is considered, it's been around a long time, it's considered a nonpartisan organization. I put it on a back slide in terms of links. It's someplace you want to go to look at in terms of what's going on, because they try to stay current on what's happening with refugee populations. Again, we know in the news we have people who describe refugees and immigrants kind of on both ends of the scale. You know, they're all criminals, they're all productive, law-abiding citizens, and we sort of ignore the continuum in between those two areas. The Migrant Policy Institute just recently did a study and found out that about 7.5% of illegal immigrants are convicted of a crime in about 2.7% of a felony. So it's inaccurate then to characterize the entire population as being criminals. We see that, I think, a lot in public health with, you know, scapegoating and all of this or none of this, and we know very well that there's a lot of space in between those two extremes. I mentioned DACA support. 74% of people just recently in a poll by Pew reported support for the DACA situation, making those children who came here as babies with illegal parents but who've lived their entire life here legal citizens. So watch what happens, because that's that March 28th, 2018 deadline, and we keep kind of punting that ball down the field. So we'll see what happens. March 2018. March 2019. They punted it again. I'm sorry.
It was March 2018.
What?
It was March 2018.
Yeah, it was March 2018. Yes, that's true. They punted it, but again though. So we'll see what happens. Research attributes anti-refugee sentiment sort of to three categories. Again, from a public health perspective, we work with vulnerable populations in many respects. This all sounds pretty familiar to us in terms of how people feel sometimes about the populations that we are interacting with, in terms of, are their cultural beliefs the same or different than ours? How do we feel about that? The economic picture in terms of how many resources do they take, and I'll talk about this again in a few minutes. How many resources do they take? Are they taking resources away from us? Are they taking jobs away from us? That floats around in Indiana quite a bit in terms of that process. Then you talk to the employers of some of these companies who really want workers. And I suspect, like Indiana, we have mixes in terms of, you know, are they eligible for various services like WIC? We have these clinics. We've allowed anybody to come to the clinics to a sliding fee scale for people who aren't under some kind of insurance plan. But different communities respond in different ways in terms of what kind of access and what kind of services are available to refugees. I work with, we have a couple of work study students in our department from who are Muslim from countries, and they can't accept certain kinds of scholarships. They can't do certain things in the university, and so the most support we give them is hire them as work study students in our departments. So, again, it'll vary from state to state. So economics is an issue, as is the whole area of ideological differences in terms of different religions. My students did not know very much at all about Muslims and the faith of Muslims, and so just educating them and having them interact. We had, because this is a Homeland Security Preparedness class, we actually had some international students, so we had some Muslim students, and just talk about some of the similarities versus always focusing on the differences, and it was surprising to all of us, I think, in terms of how much the Quran talks about Jesus and some of the things that we think is part of our Christian tradition. So things that we need to look at and address. And I think, this is the best picture I could find to kind of help me think about. As a country, I think we're sort of zipping in, we're turning in. We're going to go through a period of time where we're not as receptive to people coming in from other countries. And some of us would say that that makes us less strong because pluralism is what made the United States the country that it is. It's against our principles. Internationally, are we doing our fair share in terms of we have a huge refugee population, and I'll show you some stats in a minute. So internationally, what does this do to our standing? We're sort of taking a posture right now that we're not as concerned about that piece. We talked in my class a lot about does that enhance the negative stereotypes about the United States, and so does that actually lead to a more radical thought among people versus not doing so? We don't have answers to all those questions. And other people would argue that it's what we need to do. It's been overdue, and that we need to do it in terms of our value. These are the statistics. Globally, we have 65.6 million people who are displaced, 22.5 million refugees. We probably are going to take 21,000 in this country this year, the total refugee population. So it shows you what's going on. Most of the refugees today are going to Turkey, Lebanon, and Pakistan. And let me show you another slide in a minute, and I'll talk a little bit about that. This is what's happening in the United States. We sort of hit a peak just before the administration changed, and now we're on a different trajectory. This shows you a much longer period of time, and it shows you where people are coming from. And I know it takes a while to really look at this, so I suggest you look at it later. It'd be interesting to put the historical events and line it up with this calendar in terms of why these kinds of refugees at this time. You can see where we are in 2018. Almost no European refugees. We had some of them in the late 80s and early 90s. So changes over time. These are the major countries from which we've gotten refugees in the last number of years. Quite an assortment. I think I heard this morning on the news that Democratic Republic of Congo is experiencing an Ebola outbreak, and some of you did that as well. That will be, so I'm sure every public health person in the world's ears kind of perked up when that hit the news. Religious affiliation, this too I think is an interesting slide from the Pew Research Center. It shows you the mix in terms of Christians, others, and Muslims, and we certainly in the last couple of years, again, because you think about where the refugees are coming from, it makes sense that there would have been an increase in terms of Muslims. The study that was done by Pew said that Muslims who are foreign-born versus U.S.-born have very similar religious practices, so those are holding pretty steady, but the immigrants have a stronger socioeconomic foothold in the United States than do those who were born in this country, and they tend to be more positive about their status, which is an interesting piece of information. How you take that and translate it into usable information is something that takes additional thought. So what's going on in the main states? I guess I didn't put them in the right order, did I? That's my rebellion that you have a name when we don't. You had 852 refugees so far this year in 2018. You can kind of see the bigger states in terms of how many numbers they have. Ohio has the highest number, which was a bit of a surprise to me when I first looked at the data. Probably New York, California, and Illinois are seen as the states that are most rebellious in terms of how they're dealing with sanctuary cities and ICE and so forth. So those are interesting states to watch. So this is 2018. Total in the U.S. about 10,500. Total in the main states of about 852. This is 2015. You had in your states a total of 4,159. So you can see that there's been a dramatic drop in number of refugees. But the research shows that refugees, the University of Nebraska Medical Center did a very interesting study that looked at kind of more long-term what happens with refugees' families, and they said, we still need to be paying attention to and thinking about what kind of resources and assistance they need 5 years out, because they're not very well settle at even that period of time. And we think in the system that we can do this in 30 to 90 days. That's sort of how we've got the system established to be of support. I brought sheets about each of the states that, if you'd like to take it away, that gives you sort of a picture of the refugees in your state. And I know Kansas City, and I know St. Louis, I know some of the major areas have done some pretty interesting studies and compilation of refugees in your state to add to that piece of information. So, what if I want to come to this country and I'm a refugee? It takes about 18 to 24 months. Under good circumstances, they say now it probably takes twice that much time. So people don't get to this country quickly in terms of a refugee process. You have to go through the United Nations or the U.S. Embassy, get referred, get processed by the Resettlement Support Center. We have 9 centers abroad. Homeland Security has an interview in person with the individual, and it could be somebody from the FBI, it could be somebody from the DOD, a variety of federal officials do that. They go through biometric screening. And the statement is always they're screened more carefully than any other type of traveler to the United States. They then have to have a health screening. Does anybody know what they have to do for their health screening? This will make you smile, I think, a little bit. We test them for tuberculosis, which makes some sense in terms of latent tuberculosis, the need for treatment of latent tuberculosis. Syphilis, head lice, some of the diseases we did 100 years ago in terms of screening individuals. This health screen is very focused on infectious diseases. And some of that probably makes good public health sense, and some of it probably does not. But it sort of harkens back to what we did when people came through Ellis Island, and we were looking at them in terms of their issues. Then they get if they're approved, they get and don't have any diseases of public health significance, and people can sort of interpret that the way they'd like to. So that might be interesting to us. Could somebody do a study of what all shows up on people's list of diseases of public health significance, because we may or may not agree with them. You get a brief cultural orientation. Each person is given $2,000 from the federal monies to try to help through that early resettlement days, and then they are affiliated with some organization. Refugees right now, and I say right now because I don't know what's going to happen in the future, are eligible for Medicaid in most states for a short period of time. And again, the literature suggests, and the studies that have been done, that what sometimes happens with people, they get Medicaid for a short period of time, so it's a window of opportunity, but they can't get in to see a medical provider during that period of time because all of our primary health care people are overwhelmed in terms of their system. And so Medicaid may run out before they actually have an opportunity to interact with a healthcare provider. So that's something we need to think about in public health, in terms of how can we maybe modify that so that happens. On the other hand, Medicaid may go away in terms of being a part of the process. This is a picture of the same kind of process. If you'd rather look at that kind of process, you can do that. So what comes next? You're in this country. Children are eligible to go to kindergarten through 12th grade, as are other children. When it comes to higher education, there's a really interesting debate going on right now that should we allow, like a refugee who grows up in Indiana, gets to college age, should we allow them to have in-state tuition or not? 2 of your states, Kansas and Nebraska, have already passed laws saying no, they are not eligible for in-state tuition, even though they grow up in the state. That has happened in some other states as well. It hasn't yet happened in Indiana, but I'm expecting that it might very well happen. We just took up a hotly debated issue about should we allow in-state tuition for people from Native American tribes who were part of Indiana that we pushed out of Indiana, and now they're coming to Purdue to go to the university. Should we allow in-state tuition or not? That too has not been resolved as an issue, but it's an interesting sidebar to this kind of work. We've always had in our country some hesitancy about refugees. I know there's some pretty interesting historical research to say that. On the other hand, if you look, when Gallup did a poll just recently, support for refugees is not changing a whole lot in one direction or another, but it's still fairly strong. But the populace is not having the final say in many of these issues. I think that from a public health vantage point, again, we are accustomed to working with vulnerable populations. We know something about the disenfranchised in our communities, and I think this is another population of disenfranchised people often that we can help educate people about what's the data around our refugees in our communities. How can we think about celebrating the similarities and differences so that we have some ability to have some positive ethnic identity in populations. And I think public health needs to be leading by example in terms of what we're doing with this population and other populations. Something I think people are not thinking about a whole lot is what's going to happen to the healthcare workforce related to refugees and immigrants. 2.1 million immigrant healthcare workers are employed in the U.S. healthcare system. 2.1 million. And then I've broken it down by what areas they work in. And physicians are the highest percentage in terms of somebody who's foreign-born who works in our healthcare system. And again, I'm sure you see that on a regular basis because we have foreign-born health providers throughout our system. This is one of the areas where our present administration would like to crack down. And you look at it in the sense of what's going on with healthcare. Do we have sufficient healthcare providers, and should we be doing this or not doing this? I haven't heard healthcare organizations think about speaking out about this issue, but I think we need to think about it because it will present problems. That's one of the arguments we made in Indiana about, wait, you're not going to license people in Indiana if they have a green card? Really? That's going to have a huge impact on our workforce and our healthcare systems. Do we really want to do that, and what do we think we're trying to accomplish? I think maybe nursing has done more with this than some of the other fields have in terms of processes, in terms of foreign-educated nurses and how do they apply for licensure in the United States. We actually have a fair number of people who are trained as physicians in their home country who get to the United States, cannot practice as physicians, and so then they enter our nurse practitioner program and they become a nurse practitioner in a 2-year period of time after they get settled. And so, you know, it's sort of been a bonus to us because they tend to be very well educated, very knowledgeable individuals who pick up and move very quickly through our graduate programs. But it's not quite the same practice that they had in another country.
Iowa, because it's so hard to find trained clinical laboratorians, especially for the rural labs,
Yeah.
we have a pipeline to Philippines.
Oh, you do?
And we have a lot of Filipino trained laboratorians come up, which we're starting to see happening more around us.
That's interesting. Nursing kind of went through a period of
Yes.
time where we had a lot of Filipino nurses imported to this country. Malawi was another place where we had a lot of nurses coming from Malawi to certain parts of the United States, and it became a kind of a reverse issue in terms of people. The Malawians were saying, you're taking our healthcare workforce and sending them to the United States and leaving us without. So there's a flip side of that as well. But if they can't enter the country in the future, that will be. We'll have to have other solutions to some of these things that our foreign workforce has been beneficial for. If you, again, like graphs, this shows you where the people are coming from, and please take some time later and look at that, but you can see. So another question people often ask, are immigrants a drain on our healthcare system? And there was a study done, Harvard School of Public Health and medical school did this study and found that immigrants actually contribute more to Medicare than they receive in terms of benefits versus those of us who are on Medicare, and U.S.-born people are more of a drain on the system. The caution with this is that immigrants tend to be younger than we are in terms of our demographics. So you need to have an analysis of this in terms of specific ages, because if you're 65 to 70, it's probably very different than if you're here 90 to 95. So you have to be careful about some of these studies in terms of what are they really saying, and have they controlled for all the things that we should. Other studies have been done suggesting that they use less health care. That's not necessarily a positive thing either in terms of just not utilizing health care when they should be utilizing health care. So we certainly need a study in this area, much more research. So now, again, we're going to try to, just a few of the pieces for specific populations. Young children now, the latest study I read said that 1 in 4 children in the United States has at least one immigrant parent, if not 2. 1 in 4 children in the United States. That's 25% of our kids. That's a pretty significant amount. They tend to have lower infant mortality and low birth weight than native children. The thing is, they might have an initial advantage in terms of some of their health situation, but when they kind of reach that young preschooler period, you begin to see a shift in terms of what's going on. And Van Hook did a study, it's been a couple of years ago now, that said that was related to food insecurity, that these populations have a huge problem with food insecurity, not sufficient food, their socioeconomic status, how well are we doing in terms of language proficiency with parents and children. Children maybe are better attended to than our parents, and what kind of climates do we have. So what are we doing for children? We know from other kinds of research that with children, you want to, if you have a refugee child coming into your community, you want to normalize their life as early, as quickly as possible, have a routine, get them to school, whatever needs to be done, because kids like boundaries, they like routine. They tend to do better in that situation. Mental health needs, when you think about why refugees come about, it's because they've witnessed or experienced themselves a lot of trauma, so they could have had a painful situation in their country of origin, violence and torture on their way here, loss and change is huge, long waits, overcrowding, social disconnection. The SWIFT studies have found that unaccompanied children and women are most vulnerable in terms of some of those factors. So mental health is a big issue. Jim Mattis said at a hearing of the Armed Services Committee that he thinks the refugees coming in from Syria are the most traumatized of any of the refugees he's seen over his career in the military. And so there was a study done of Syrian children that you can look at more closely in terms of the kinds of things that they've had to deal with in terms of their situation. So settlement in terms of mental health depends a lot on what's kind of pre-immigration, post-immigration status, what kind of family separation they've experienced. That's where I said at the beginning I was worried about this kind of closure of how many people can come under a particular family's entry, because those things make a difference in terms of settlement. I think we've talked about most of these things. I don't know about your areas, but where I live, mental health providers are in very short supply. We are very understaffed in terms of mental health. We just started today our psych mental health nurse practitioner program, because we started a certificate, because a lot of nurse practitioners realize that mental health is a huge part of their role, so they're coming back to do that, and then psych mental health nurse practitioners as a degree. Our community and our community foundation is supporting that program for 4 years because they just don't have enough providers. So it was a good way for us to be able to do that. Now nutrition is an issue. Again, you can look at that in terms of what's going on. And again, what kind of eligibility do they have? Are they eligible for WIC? Some places they are, some places WIC doesn't allow various groups to be engaged. What about food banks? Actually, in general, the research shows that immigrants probably use the food bank more than do native populations and communities where there's a representation of both, which again probably relates to their food insecurity in terms of what's available. Infectious disease, that's sort of where the history is. You know, they are restoring Ellis Island, the hospitals on Ellis Island. That's on my bucket list of things I'm going to do now that I'm going to have more time on my hands. I'm going to go check that out. I think that would be pretty interesting to look at the history of Ellis Island. And so over time, you know, we've often blamed immigrants for the diseases that come into this country. So it's a pattern we've had for a very long time. And now you can actually exclude people because they have some kind of infectious diseases. We did that earlier in our history, and now it's back in terms of doing that. We can also exclude people if they don't have the right immunizations. The study that was done by Boston School of Public Health showed that immigrants are supposed to be receiving immunizations when they're getting screened in another country, and it's not happening to any great extent. So as public health people, I think we want to pay attention to that when they get to our area. Are they really immunized, and how do you sort out? Did you have on the state level like a directory of immunization labels in different languages? So if you have a lot of refugees from a certain country, you can get some information. That's usually available through CDC if you don't have it at a local or a state level. But again, just the kind of the history. Remember HIV in the 90s, all green card applicants were tested for HIV, regardless of their status. We did that. SARS in 2003, we tried to figure out how to screen airline people. We had fewer stations at airports to try to see if somebody was coming in with SARS. Ebola, we learned a few things when the Ebola situation came about. It didn't take a lot of cases, and we had what? Again, in Indiana, there was kind of mass hysteria. I would assume that happened in your states as well, in terms of what would happen. So I don't think we have all those things worked out terribly well. Zika. When I got involved with Zika, this was pretty interesting. There was a discussion about how do we close the borders for Zika. How do we manage that? Now, from a public health vantage point, what would you think about trying to close the border for Zika?
Kill all the mosquitoes?
Yeah, like, you know, check in at the border, please. Turn around if we find you positive here.
Bring in more bats.
Yeah, bring in more bats.
Putting that back out there. I've been thinking about it.
They don't always eat the right mosquito.
We're going to stop Zika at a border? Like, what do they not get about mosquitoes? Have they never seen a mosquito? It was pretty hysterical.
And troubling.
And these are people with, you know, great degrees and do wonderful work, and then sometimes those practical little things like how the mosquito flies just totally escapes. So, but when you figure it out, let me know so that I can work really good with my colleagues and go in with a clear way of managing to keep mosquitoes.
Just a big mosquito net.
Mosquito net. That's what we can do. A big mosquito net.
Yeah, just
instead of a wall, we need a big mosquito net. That may have more merit, and it came right out of the big group that you that group. So let me know when you make national news and get that accomplished. I actually think all of these viral diseases are going to be challenging for us. Not just Zika, but chikungunya and dengue fever. Those are all. And Zika totally surprised us with sexually transmitted disease as well as its more conventional ways of transmitting things. So pretty interesting. So I think there's going to be work for us in public health for a very long time. I don't think any of us have to worry about job security. I think we do have to worry about economics in terms of how well we're recognized, how well you're recognized for the work you do, and reimbursed appropriately for that work. Actions. Again, we know about good public health practice already. We already know about collaboration. Public health is all about collaboration. It's not a surprise to us. You have to collaborate with other organizations within your state or your local area. We know that we want to counteract ethnic scapegoating messages. Any logic. Has anybody heard about any logic? This is something you need a bright young student, graduate student, to do this. Any logic is software that you can actually model what happens if you're introduced, like you introduce Zika into an environment. It allows you to do modeling and put that out for, like, you can run it 1,000 times. That's what we do, is we'll do something, we run a pod, we estimate how much time it took us, or we not estimate, we'd actually have people with stopwatches. How much time does it take to get through the stations? And then they would put that in the model and look at, well, how many screening stations do you really need? How many dispensing stations do you really need? Does that line work to set it up this kind of way? We've done this about 10 times with different models, and it's really been interesting in terms of how much people power you can save by applying that kind of software to the process that we have. Right now we're looking at how accurate are we when we dispense, like at anthrax where you have 3 different medications that you want to dispense. How accurately are we dispensing those? And are there ways that we can, again, think about doing it differently so that we have better outcomes? We have an error rate of about 10%. It's been, the lowest it's been is 5%, the highest it's been is 10%, but it's a pretty stubborn rate in terms of what's going on. And Judy Monroe, who was at the CDC and is now at the CDC Foundation, is our former state health commissioner. So we're talking with her about how do we, anybody run a pod recently? Do you have to exercise your pods in your state and local areas? We're trying to look at how do we bring that number down? Because I think that's an unacceptably high error rate. And when you think about doing that in a time of emergency where you're bringing out kind of people like me who might be retired, or people down here at the other end who might be retired, and we want to use you in our pod, but you're maybe a little rusty in terms of your skills, which I will delightfully do in a couple of years. How do you get them to dispense the right medications, and what kinds of things can we do? So any logic allows us to speculate and do different kinds of things with just a little bit of data and play with it. So I went to 3 days of training for any logic. I was still back trying to do my little model of my airport, because we were trying to look at what happens when you introduce a disease at the airport. I'm still trying to get my boundaries set up in my airport, and students are, they're setting people through already, and it's not working out so well. Clearly there is an age advantage to this process, or I missed that somewhere along the line. But it is powerful. We need to be employing those kinds of tools, I think, in public health, but we have to partner with the people who know how to do this. I brought along the forms for Immigration Service. If you've never seen those are pretty interesting, because again, they're focused primarily on infectious diseases. Chronic disease, an area where we haven't done a lot, but we need to be looking at in terms of, what about diabetes and heart disease? Just been focusing primarily on infectious diseases. So I think our challenges are, we don't have enough interpreters, we don't have enough people who speak the language who can go back and forth between the two. And in healthcare, it's very difficult, I think, to use children as interpreters. It's a really uncomfortable place for children to be in, for their parents to be. We have to deal with gaps in education in their home. If they've been living in a refugee camp for many years, their education has been interrupted. We probably have to try to help improve that. Very limited understanding of how the U.S. healthcare system works. Those of you who've been in a university working with international students, you realize very quickly that people do not understand the U.S. healthcare system and how it's set up and how eligibility works. It's very complex to people because it's very different than their own systems. Our students, you have to make an appointment. They just don't understand that you need to make an appointment to see somebody. They just want to come in, and then they want to come in, and if I'm here first, if my appointment's at 3 and your appointment's at 2, and you get there 5 minutes before 2, and you get called in first, that totally befuddles them in terms of, wait, I was here long before you, or what's going on? So it's a appointment system, just a simple little thing that sometimes creates issues. Then you've got what our pharmaceuticals are made of. If there's pork and beef in pharmaceutical drugs, are we aware of that? Do we think about that? Maybe need to prescribe something different to that population. How long will they be eligible for Medicaid? In our state, it's 3 months. I don't know what it's in in your states. What about our own cultural sensitivity? You know kind of, and if you don't know, there's the sheet will tell you where your refugees are coming from. What do you need to learn in terms of that particular country, and get some background in terms of that population. Refugees are sometimes seen as manipulating the system to get resources. That sort of speaks to that issue about they're a drain on society rather than a help to society. So we may have to counteract that as well. And I've given you some sources. Actions, I think these are all things that, again, we in public health are attuned to. We just need to apply to this population. I think there's an interesting thing going on in some of the major cities now with using artwork to help refugees and other people understand different populations, and allowing them to paint their shelters in bright colors and with images. Here's some links of places to go for information. Minnesota State Department of Health has a lot of good information in terms of a health department that you might look for, and then there are others as well. I want to thank you for this opportunity.